Hi, I'm Dr. Frank Speidel, and welcome to The Doctor Is In. In this program, we will look at healthcare in the United States, how we as individuals and as a society experience and interact with healthcare. I intend that these explorations of healthcare be skeptical and fact-driven, that we ruthlessly question many of the comfortable concepts we have reflexively accepted. With much good cause, much is written and discussions abound about our annual spending for healthcare. Currently, healthcare expenditures make up about 18% of the GDP. Now, when examining expenditures over time, economists rightly stress to assure the items are purchased in '79 are the same as the items that are purchased in 2019. To use the phrase of art, the market basket of goods purchased over the same time period should be the same. In healthcare, this concern is massive. In evaluating patient care in 1973 for a headache, the appropriate imaging studies might include cerebral arteriograms and even a pneumoencephalogram. And as we have discussed before, high-resolution contrast CTs of the head is order of magnitude safer and provides a deluge more of actionable information. The market basket of goods has changed. But beyond this change in the information and safety of imaging study, imaging has ventured into therapy, and it is a brave new world. In the mid-'70s, I saw a 26-year-old man in the emergency department of a university. He had been thrown from his car in an MVA. His blood pressure was low from blood loss due to his pelvic fracture. Despite massive transfusions, compression, and an outstanding surgical team taking the patient quickly to the operating room, the patient expired. This tragedy brings us to today's guest, Dr. Robert Worthington-Kirsch. Had Dr. Worthington-Kirsch been available, then things would have been different. Dr. Kirsch is a remarkable individual and physician. He is one of those people who makes the sad world sing and dance. I pride myself in having been blessed to count as friends some of the finest, most sensitive, kind, and brilliant this sad world can offer, people like Dr. Rob Kirsch. He is simply one of the brightest people I have ever met. And not just in medicine. As many of the wickedly smart people I know, their curiosity knows no limits. Rob never ceases to surprise me at how many things he has interest, competence, and comprehension about. As befits the polymath that he is, all of medicine, not just imaging, is in his domain. Not surprisingly, he is not just a national leader in interventional radiology. He is a global expert in interventional radiology. His patient catchment is literally the entire globe. Dr. Kirsch, welcome to The Doctor Is In. Thanks for joining us, Rob.
Thanks, Frank.
How about some background? How'd you become educated the way you are? Tell me about your training. Where'd you get this wonderful basket of knowledge you have?
So I grew up in Boston. I went to Boston Latin School. Then I went to college at MIT. I have a double major in basically molecular biology and comparative Western religion with a minor in ancient medieval European history from there. The comparative religion was actually fulfilling Wellesley College's requirements for their major by exchange. And then I went from there to University of Massachusetts Medical School, and then I moved down to the Philadelphia area for my training in radiology, and I've been in practice in and around this area since then.
It's easy to see why you have that massive interest in everything just by looking at your multiple undergraduate majors from MIT. Hey, what was the unit of measure that the MIT undergraduates came up for in measuring across the bridge there in Boston?
Oh, now I'm blocking on that, but they're smoot.
A smoot.
The smoot.
Where's the smoot come from?
There was a pledge to one of the frats by the name of, I believe it was Oliver Smoot, and as their pledge project one year, they actually measured the bridge across Massachusetts Avenue, the Massachusetts Avenue Bridge across the Charles River in smoots, and by picking him up and lying him down. And there are actually marks on the sidewalk that every year the pledge class of that frat repaints.
I like that. I like that. That's a good Jeopardy question. I've been in awe in your extreme command of medicine. Many people know their specialty and their subspecialty one. You're one of the people that if I had a question about something beyond just imaging, I would go to you and say, Rob, what is your experience with Alpha Bravo Charlie? And you almost ended up giving me citations for things. How did that happen?
Osmosis. I mean, in interventional radiology, I could at one point, at any point in the day, be asked to address a medical problem from any body system. So there's a lot of stuff you have to learn about, and sometimes they ask me a question, and the next thing I do is use Mr. Google. But although back then we didn't have Mr. Google, we didn't have Mr. Google.
That's why I used to go down and ask you, what do you know about this?
And I had Harrison's medicine, but it's just, you have to pick things up. And, when I've been asked to treat a patient with a certain entity, I try and learn about it. And, it's amazing the amount of stuff that sticks in your head.
Tell me about the breadth of interventional radiology. Is there any organ system you're not involved in other than psychiatry?
Interventional radiology is sort of the needle and catheter part of imaging. So we do things that most people would think would require surgery using imaging guidance and very small instruments through very small incisions or even no incision, just a puncture site. We can get anywhere in the body and address almost any organ system. Historically, the heart is generally the property of the cardiology groups, although there are radiologists who do cardiac cath and cardiac interventions. But aside from the heart, there's nothing that I haven't been asked to treat at one time or another.
Talking about the breadth of interventional radiology, in neurosurgery, folks that are suffering from aneurysms, sometimes they traditionally had no options because where that aneurysm is, or that AVM, atrial venous malformation, was not accessible to surgery.
Right.
What happened with interventional radiology? You guys came along and...
Interventional radiology in the central nervous system is now, there's arteriovenous malformations, which are tangles of blood vessels in the brain, which can cause problems both by pressure and because of bleeding. There are aneurysm, which are little sort of balloons off the side of an artery that are at risk for rupture. And then the other thing that's very recent in interventional radiology is being very aggressive about stroke therapies. And basically, all of these things are in one way or another related to the circulatory system. So for AV malformations and also for aneurysms, we can basically block the abnormal section. We can fill the aneurysm with little metal coils that look like steel springs. We can fill the AVM with basically super glue or another adhesive, and then plug up the blood vessels leading to it with more of those coils. And for stroke therapies, we can go in, and there are techniques for aspirating pieces of clot out of the brain, for opening up areas that have had some clot develop in the blood vessels, for stretching open vessels that have gotten narrow. Everybody's heard of having angioplasties in the heart and having stents put in the heart, and we can do the same thing in the brain, in the rest of the body, in the gut, in the legs, all those places.
One of the popular things recently in the past year has been, I shouldn't say the past year, the past 8 years, has been Game of Thrones. One of the leading actors in that, she unfortunately apparently had a cerebral aneurysm, that she had an intervention, they took care of it, and she didn't miss a season.
Right. When we do Now, I don't personally do neurointerventions anymore, but when they do a coiling of an aneurysm, the procedure typically takes about an hour, is done through a puncture site in the artery at the groin, or even possibly even at the radial artery. And at the end of the procedure, you close the blood vessel and you put a Band-Aid on it, and after an hour or so, the patient gets up and walks out.
What's the success rate with these? I know that the results were very scary, depending on the operator, for an open clipping of an aneurysm. I suspect your success rates are putting some neurosurgeons out of business.
I think some neurosurgeons are learning to do this. But I can't quote you exact success rates, but they're pretty high. If somebody's got an aneurysm, particularly if the aneurysm has good anatomy, if the aneurysm has like a relatively narrow connection and a narrow neck where it's connected, so you can get a catheter into the aneurysm, coil it, and you don't have a high likelihood of anything spilling out of the aneurysm into the normal artery. It's a technical question, and if you've got the technical skills to do it, each case is different. But if you've got the technical skills to do it, they're challenging, but not incredibly difficult.
My 26-year-old who was ejected from his car that night, you know what open pelvic fractures are like. What does interventional radiology have to offer this person in trauma?
Well, in the mid-'70s, you didn't have much of anything. You could get an X-ray, but now we can put somebody through a CT scanner. We can identify the fractures. We can also identify even points of bleeding, which you can see when you inject X-ray contrast into the veins. You can actually see where it's spilling, and then you can take the patient to the angio suite, and you can go and find those areas where the vessels are torn, where the vessels are bleeding, and plug them up. We do that for bleeding from trauma. We do that for bleeding from aneurysms. We do that for bleeding from tumors. We do that for bleeding after childbirth. We do that for almost any kind of traumatic bleeding. And we can either use medications to clamp the vessels down so that they stop, or we can put a temporary block in that gives the vessel time to seal itself up and then will dissolve. Or we can, if we need to, we can put in something that will permanently block the vessel.
When did this kind of intervention start? When did it become common?
We probably started doing this kind of embolization in the mid to late 80s, even the early 90s. And for the last 15, 20 years, it's been common at places where the skill set, where physicians with the skill set are practicing. So almost any university hospital or academic hospital has plenty of people, and many larger hospitals. Unfortunately, there are lots of small hospitals out there that don't have an interventional radiologist available, or don't have an interventional radiologist available every day.
Sometimes I've thought they didn't even have an awareness of the options that interventional radiology provides, which is one of the reasons I'm glad you're on with us today, because I look upon this as kind of a public service. Tell me about your practice. What are you doing?
Well, for the last 8 years, I was in a hospital-based practices for most of my career, and in 1994, I started performing a procedure called uterine artery embolization, which is a treatment for fibroids in women. Benign tumor of the uterus causes significant symptoms, and traditionally treated with surgery, usually hysterectomy. And again, we go in through a puncture site at the groin. We find the blood vessels supplying the fibroid. We block them, and that takes me about 15 minutes. And the vast majority of patients have major, if not complete, improvement in their symptoms. So I was doing that in '94, and then in about 2009, 2010, I left a hospital practice and started with an office-based practice. For the last 8 years, I've been with a company called Vein Clinics of America. We have 65 offices in 15 states, and the vast majority of my practice now is treating varicose vein disease. I started treating varicose vein disease in 1999 or 2000, largely because it's sort of the same patient population. It's otherwise healthy adults who have life-limiting disease, whether it's fibroids making their periods heavy and long and miserable so that women are trapped in the house because of how bad their periods are, or whether they have varicose veins that, because of the abnormal blood flow, give them heavy, achy, tired legs with swelling and limit their ability to go about their usual activities. So both of these disease entities are life-limiting. They're not life-threatening. But I've got a toolbox of instruments and techniques that allow me to treat these disease entities, and there are others, with very high success rates and very low complication rates, and lets me give my patients their lives back. And that's very rewarding. That's why I go to work every day.
Many people who are well and healthy, and I kind of include myself in that subset, we tend not to think twice about the limitations that people that appear to be young and healthy have. And this is clearly one of them. I think uterine fibroids, as you and I both know, are a devastating illness for a young, otherwise healthy person. Do fibroids affect fertility?
The relationship of fibroids and subfertility or infertility is very complicated and not real clear. It is obvious that if fibroids are in positions in the uterus where they can block things, then they can interfere with pregnancy. Most women with fibroids, if they have problems with fertility, they probably tend to have multiple miscarriages rather than an inability to get pregnant. And certainly if you go and have a hysterectomy for your fibroids, you can't have a child. And if you have a multiple myomectomy where they sort of open up the uterus and start shelling out all these fibroids, that has its own set of issues that cause problems with fertility down the line. Certainly there are women who have one good-sized fibroid that's in a surgically accessible place, and going in and sort of carving that one fibroid out can do wonders for their fertility. But those patients are relatively few and far between. Most patients have a uterus that, pardon the expression, looks like a bag full of rocks.
Yes. But with a uterine artery embolization?
After uterine artery embolization, there are women who've become pregnant and carried to term. We don't have a huge amount of data. My personal best guess is that fertility after uterine artery embolization is certainly no worse than it is after myomectomy, and may well be better. But that's something that would require a huge study that nobody's doing right now.
Speaking about studies, I was fascinated. You're one of the few physicians that I've known has done, the FDA has different phases of studies for devices and for drugs. Is there any phase study you haven't done? You've done phase ones, haven't you?
No, I haven't done phase ones. Phase ones are establishing that a new drug's basically not going to create any disasters. I've done phase 2 and phase 3 trials. Phase 2 trials are larger trials that go to to demonstrate that something works. And I was the primary investigator for a sort of multi-product phase 2 trial that gave the FDA the information it needed to clear some specific embolic particles for fibroid embolization. And then I've done some phase 3 trials, which are after the products have been cleared for release, and looking at longer term safety and efficacy.
Huge contribution to create the options that people will have out there. Is there a continent that you have not seen a patient from, other than Antarctica? We know you've seen people from South America used to come up to see you.
And I've seen a couple of patients from Africa, and
Europe,
a few. And I think I've seen 2 or 3 patients who have come from Asia, from Singapore or Hong Kong for treatment.
Yes. Have you seen a Japanese patient too?
I don't think so.
I thought you did. I was just fascinated because literally you cover the globe with your patient population, and you've got such a good reputation for that. What you find rewarding is giving people back the quality of their life. Do you think that there is to me, one of the saddest things is that we somehow in medicine get the idea that if you're not saving a life, you're wasting your time. And that's the furthest thing from the truth, isn't it? Because how many times have we seen a patient who we've preserved their life, but we haven't preserved the quality of life that makes them so distinctly human and able to celebrate every day?
Well, that's a big issue. There are, it's a very difficult issue because there are people who focus on different things, and there are some people who focus on quality of life. And if they weren't able to do what they wanted to do and be active, then they would rather not be in a condition where they can't do that. Then there are other people who are focused on length of life and how many heartbeats you get, regardless of what their quality of life is. But it is, I think I've got the number right, but about 3/4 of U.S. spending on healthcare occurs in the last, 90, 100 days of life.
You're 100% right about that. It's a huge number. We spend most of our resources in healthcare on that last time because those people generally tend to be the sickest.
They generally tend to be the sickest. But there's you can legitimately ask the question of whether or not that's necessarily the best way to spend our resources. We could take some of those millions of dollars and spend them on better education, better health, better water, better immunizations, and make a much greater contribution to the health of the society as a whole.
The general wellness of society as a whole. One time I was amazed at a young person with a significant facial port wine hemangioma. And I never appreciated how much that was destructive to their living their lives. Things that I am not smart enough or sensitive enough or aware about, just when they meet somebody for the first time or when they have to speak in public. They have to do incredible compensations. Makeup sometimes works wonderfully for them. But at the same time, it's still a quality of life thing that, if we have the opportunity to change that for somebody, let's go for it. If we have the opportunity to allow somebody to not be housebound because of massive bleeding, this is a huge gift. What do you see in the future of interventional radiology? What's the brave new worlds out there that you and your colleagues will be looking at?
I think the brave new worlds for interventional radiology in general is there's a lot of ongoing research and buzz in interventional oncology, in particularly developing treatments that can be delivered to cancers locally rather than the whole body. So rather than put a port in somebody and give them chemotherapy, sort of poisoning their whole system in order to kill the cancer before you kill the patient, and then let the patient recover. And that's a very crude description of how chemotherapy works.
No, I think it's a very accurate description of how chemotherapy works.
But what we do is we can get catheters into the blood supply to the tumor and deliver our agents often in higher doses because we're treating a localized area and have some effect. And there's a lot of work doing that. There's a lot of work, particularly in liver cancers, both primary cancers of the liver and metastatic disease of the liver. In my personal area of varicose vein disease, we're sort of, in my perspective, in the midst of a paradigm shift. 30 years ago, if you had varicose veins, the procedure of choice was something called stripping, where they made an incision at the groin, found the vein, opened the vein up and ran basically something that looked like a straightened out coat hanger down it, and then nick that out in the middle of the lower leg and pull the varicose vein out. Over the last 20 years or so, we've been using some thermal techniques where we basically heat the vein either with a laser or with a radio frequency probe, and that is done through just one puncture access, and that treats it. And I think that we're having a big transition in that. Very recently, we've basically been using superglue. It's a special medical composition or formula, but now we just put a catheter in, we drop off some super glue, we seal the vein shut. I actually had this done myself about 3 weeks ago. And the other thing that I've been involved in recently is we're really focusing our research on not just showing that patients with varicose vein disease actually have significant symptoms, because some people, like the people at Medicare, don't want to believe that, but that the treatments that we offer really do work. And my colleagues and I are going to start on a relatively large project to get some of that baseline data. We're already starting that with myself and my colleagues at the American Vein and Lymphatic Society, and we're doing a lot of research, and it's great.
My one wish, Dr. Robert Worthington-Kirsch, is that you continue this great practice making people's lives better. And your presence as a mentor and educator for people coming up, not just in interventional radiology, but in imaging and medicine in general, I hope that continues. Thank you for being a guest today. Hi again, this is Dr. Frank Speidel for The Doctor Is In, and thank you for joining us today.
Thanks.